Hi, I'm Dr. Dave Samra, sport and exercise physician from Sydney. In this brief video, I'll explain what insulin resistance is and what you can do about it. Insulin resistance is a condition that is at the heart of many of the illnesses we face in Western society and also now in developing societies. In my practice as a sport and exercise physician, I commonly see insulin resistance in athletes, and in particular, we see it after their retirement. I also see insulin resistance very commonly in patients who come to see me with tendon and joint aches and pains. You may have heard of this condition, or a doctor may have in fact diagnosed you or someone you know with this. The term insulin resistance is readily thrown out there. What does it actually mean for you and your metabolic health? Now, this is not an easy topic to understand, but in the next several minutes, I'll distill the latest knowledge on insulin resistance to explain the root cause and the triad of targets for long-term management of this condition. The first thing you need to understand is both the role of insulin and the insulin receptor, because this is at the heart of the problem. Every hormone has a receptor that determines whether its chemical signal will be translated into the action that it's meant to stimulate. Insulin is a peptide hormone and it's released by an organ in the middle of the abdomen called the pancreas, indicated here in blue. And the net actions of insulin are to store energy and prevent the use of energy at the liver, muscle, and fat tissue. It also slows cell turnover and breakdown of cells, so it is indeed an anabolic hormone. Now, I want to just make special mention here of one of the important actions of insulin in that it normally puts the brakes on the liver's production of glucose. You can see here the left of the screen. And it's for this reason that people are generally first diagnosed with diabetes rather than the pancreas burning out and not making any insulin to push the glucose out of their bloodstream. They in fact make too much glucose from their own liver in the early stages. Now, the beta islet cells of the pancreas respond normally to what we call a glycemic load or a glucose load in the diet by producing this hormone called insulin. And it's just like a thermostat or any other homeostatic mechanism. The insulin is supposed to help control rising blood glucose levels by disposing of that glucose into our tissues for storage and use. But it's important to realize that different macronutrients have a different profile or effect on insulin production. And carbohydrates here in green clearly have the strongest stimulus by far and the total area under the curve. And this has been mapped out in multiple physiological studies. So here is the normal process of glucose disposal into our tissues when we eat. In an insulin-sensitive person, they can efficiently store glucose that comes into their mouth, then into their bloodstream. The little green hexagons you can see here represent the glucose. They have to get across from the bloodstream into cells, and they do that really efficiently, and especially in muscle. And so they can dispose of dietary carbohydrate very efficiently. The fat cells don't take up too much of the remnant glucose, and the liver doesn't overproduce glucose either because the insulin there correctly attaches to its receptor and suppresses the liver's excessive production of glucose. So that's what insulin sensitivity looks like in a nutshell. In terms of energy usage, insulin sensitive people can have low enough levels of insulin for long enough that energy use in the form of fat oxidation or fat burning is promoted. They can take in a lot of fat and the breakdown products of fat and run that through their mitochondria to produce energy at rest and during exercise. And when necessary, they can also engage glucose burning for those fast twitch fibers that prefer glucose. Insulin resistance starts in the muscle cell. That is a critical component of the more recent knowledge we have on insulin resistance. It's the inability of muscle cells or myocytes to take up glucose because of intramyocellular lipid deposits, fat depositing within the muscle, or more correctly termed diacylglycerides. This slide outlines the cellular mechanisms for insulin resistance. This is a summary of the 20 years spent by Jared Schulman, an endocrinologist in the States, and his group, who used technology called nuclear magnetic resonance spectroscopy, basically using MRIs to work out the flow and conversion of different molecules in the cells of the body. And it was his group that worked out that insulin-resistant patients have these diacylglycerides, or DAGs, that deposit in their muscle cells. Now, the technical explanation, which is outlined here, for why the insulin receptors break down and stop seeing the insulin signal first in the muscle, is that the unbound electrons from these diacylglycerides muck up the whole process. And the normal cascade that you can see running down, that should normally activate the bottom of the flow, called the GLUT4 vesicles, to go and open up a channel to let this glucose in, is that right at the top here, where the diacylglycerides are, it blocks IRS1. IRS1 is one of the first chemical messengers in the process, and it's because of increase in an enzyme called protein kinase C theta. And this blocks the whole process, and therefore glucose can't get into this muscle cell. It's still sitting down on that bottom right on the outside of the muscle cell, and it can't get in. Now, that's what happens in the muscle. What about the liver? Well, this is a liver cell, or a hepatocyte, and in insulin resistance in the liver, it's different to insulin resistance in the muscle. Looks similar, but here's how it's different. So the diacylglycerides are still there. You can see them highlighted in red. And when things go wrong here, the insulin signaling pathway is also blocked right up the top. But the job of this pathway in the liver is to block the excessive production of glucose. So it's the end result that's mostly different, even though the process is very similar down this stream. And so the glucose can still get into a hepatocyte or a liver cell because they have a different gate at the front here called a GLUT2 receptor that opens up that channel, and that's always there. So the higher the level of glucose in the blood, well, the higher the level that gets into the liver cell. It's a passive process there. But the main job of insulin on the liver, and the main effect of insulin resistance, is that there is a loss of control over high glucose production. In other words, the net effect here is that patients get high blood sugar levels. And again, it stimulates high insulin levels again, because if you have high glucose in your blood, the pancreas will detect that and make more insulin. So this becomes a nasty cycle. And this is how I try to explain things to my patients in terms of the way insulin resistance affects their ability to store and utilize energy. There is a spectrum of insulin sensitivity between an elite athlete and an insulin resistant or diabetic patient. If you imagine you're a vehicle with two fuel tanks, one for fat, which should be used most of the time, and one for glucose, which should be spared for when you need to go fast. These cars also have 5 gears of exercise, from least to most intense. Athletes can use their fat tank even when they're going pretty fast, and they only dip into their glucose stores at the highest intensities in any significant capacity. At the top of their second gear, they use a great deal of fat. This is called the fat max zone, and then glucose utilization starts to take over as the predominant source of energy production. But in an insulin-resistant patient, they've got a big fat tank, but they can't use it very well because insulin levels are not low enough for long enough to allow fat burning or fat oxidation. They tend to use their glucose tank even when they're resting, and it can run low and cause problems with fatigue and low energy. Essentially, they're locked into use of glucose when they have insulin resistance, whilst fat storage is promoted and fat utilization is very minimal. A patient with insulin resistant being able to access their fat for fuel can be a massive disruption to this process. For a person with insulin resistance to again be able to access their relatively large fat tank for fuel requires low enough insulin levels for long enough. The key is the hormonal control and the ability of the patient to be able to manipulate that utilizing their lifestyle factors and to optimize whether that signal of insulin is seen in their tissues. There are three main dietary levers of control for metabolic health in terms of weight loss, and exercise could be seen as a fourth non-dietary lever. And most patients will need to exert all three of these levers to have a benefit with weight loss, depending on the severity of their insulin resistance. So we've got here how much you eat, when you eat, what you eat, and of course your output. Rather than just telling people to eat less, we now know that there appears to be significant benefits to behaviour, the neurochemistry of appetite, and the hormonal and metabolic responses to food that occur with specific strategies, including therapeutic carbohydrate restriction and intermittent fasting. And using these in combination with some portion control is also often very helpful, and in fact more helpful than providing calorie limits for most. But essentially what patients need to take from levers of control is to own these for themselves in order to make significant changes in their metabolic health. Now, although effective, liquid meal replacement and ready-made meals that control caloric intake do have very high rates of rebound weight gain. It's important to know that in 2022, we can measure now what works for each individual, not just from weight and waist circumference, but in real time through the use of a continuous glucose monitor. And this technology is an absolute game changer. Here's a quick overview of what happens when the insulin signaling is not working. You can see here from left to right and down the stream, the glucose goes into the bloodstream from the gut, the little green hexagons there. Then the pancreas creates insulin, but the insulin doesn't open the door for glucose to enter muscles and other cells. There's as much as a 50% reduction in their glucose disposal, so that glucose is then shunted off to the fat cells. And this leads to a net positive energy storage. And then at the liver, the excessive glucose energy undergoes de novo lipogenesis. This means new fat formation. We know fructose is particularly potent at stimulating this in the liver. So we get a fatty liver, more fat deposition around our organs and in the periphery. Finally, the insulin signaling stops working, so in the liver it starts pumping out more glucose, which perpetuates the problem, increases insulin stimulus, and eventually leads to impaired fasting glucose levels. This is an overview of how we target the problems of insulin signaling. First and foremost, we can control the glycemic load, or the glucose going into the body, through the three levers of diet that we've discussed. This has to be the starting point. It's at the top of the stream and it's essential. Then we can increase muscle glucose disposal with regular exercise, and then we end up with a net negative energy status from the fat cells, and the doors are now open probably for the first time in a long time. And patients with insulin resistance are now able to access their so-called fat stores or fat tank. Finally, we need to deal with the liver's excessive production of glucose. Now, there's different agents that help with this. Obviously, diet and exercise are going to help in the long run, but in patients with significant insulin resistance, metformin is helpful in reducing glucose output, as is the GLP-1 agonists such as semaglutide. Now, these are very powerful agents, the injectable agents, and have become a very popular tool for weight loss because they also reduce appetite via central mechanisms on the central nervous system. But by no means are they essential for management of insulin resistance. Remember, at the top of the stream, the diet comes first. So the way I look at this situation is, whilst medications can be very helpful in preventing the liver from sabotaging the progress of reversing insulin resistance, in of itself, medication is not enough. Diet is at the top of the stream, and therefore the stimulus of insulin, if you are not fixing that issue, you're not fixing the problem at all. So you do need sometimes to use medication, but that's at the back end, not at the front end. In summary, we talked about empowering patients here with the 3 levers of weight loss, and we talked about the drugs that can assist in weight loss, particularly reducing glucagon and hepatic glucose output. And overall, in 2022, we have some excellent tools in the management of insulin resistance. The condition does have genetic roots for many. However, the investment in your health has to involve some form of the triad that we've talked about here. Your diet, your muscle work, and in some patients who have a liver that is sabotaging their progress, looking at agents that suppress excessive glucose output. In doing all 3 of these actions, insulin resistance can be put to sleep. I hope you found this video useful. I create these educational videos to help empower patients by allowing them to understand their problem, treatment options, and the expected recovery. Please remember, this is for educational purposes only, does not constitute the giving of medical advice, and no patient-doctor relationship is formed.